Top Med Talk.
Hello, and welcome to Top Med Talk. I'm Desiree Chappell, and we are coming to you with continuous coverage of the COVID-19 crisis from the front lines. Over the last month or so, we've been talking to people all over the world about their experiences with the care of the COVID-19 patient, and we're continue to do so to help support and educate those who are our frontline healthcare workers. Now, joining me is our editor-in-chief, Monty Mythen. Now, you have been back in there in critical care in London. Can you tell me a little bit about what's happening on the ground?
I think as you've heard it described, as you see on the television, as people read about, there's a lot of people have COVID-19, and some of those people are getting really very sick and requiring intensive care. And we've had to expand our intensive care units and provide a lot more ventilator support, for example, and alternative breathing support that we'd normally have capacity for. But wow, what an amazing team effort and response. And it's very, very difficult working circumstances, but everyone has stepped right up to the mark.
Now, we've talked a lot on the podcast about the Nightingale Hospital there in London. Have you heard any more about that?
It's great. I mean, the Nightingale Hospital is great as a backstop, and it's great to reassure people that we have the surge capacity. So far, with all the hospitals working together and networking and expanding their critical care capacity and retraining people to do a variety of tasks, we're broadly speaking managing to deliver critical care within the existing new footprint of critical care that's been created in London. Now, the Nightingale is open. You can go to regular sort of media access. You can see that the Nightingale Hospital is open, it's functioning, and it's taking patients as required to relieve the pressure.
One of the things we were talking about last week is the thrombosis story.
Thrombosis and hemostasis.
Thrombosis and hemostasis, that's right. So can you tell me a little bit more? I think we've had more that's come out about this story now.
Right from the beginning, for our colleagues who saw COVID-19 earlier, was this consistent story that there was a high incidence of thrombotic complications. Now, we all understand that thrombotic complications are a part of everyday life, if you put it that way, and they're more common in critically unwell patients for a variety of reasons, because high inflammatory states are common in the critically ill, and one endpoint for very inflamed states is to have more thrombosis in blood vessels. Mm-hmm. But people were seeing much, much higher rates than they would traditionally anticipate seeing. So there's a report come out, for example, today, I think we can put the link in the show notes, talking about there being of confirmed COVID-19 critically ill patients in a group of hospitals. I think it was from the Netherlands, from Holland, saying that about a 30% or so incidence of serious thrombotic complications. Now, it may be that we're looking harder for them. Mm-hmm. It may be that the group of patients who are susceptible to COVID-19 are also patients who are susceptible to getting thrombosis and clots. But the whole story and the blood markers we've seen change would be consistent with the fact that this is a much higher incidence than normal. People should continue to look closely for it. They should continue to consider treating, the patients on the basis of the fact that they actually have confirmed or probably have these complications. And luckily, there's guidelines being published now to help us make those rational decisions, including from the society referred to, the International Society of Thrombosis and Hemostasis.
Mm-hmm. And we were talking about this. We've talked about this before. How what we're doing for COVID patients probably put them in a little bit higher risk category for thrombosis. Yeah.
Well, I mean, that's one of the concerns that people always have, is as you try different treatments to try and help people get over the disease, there's different things that are tried that may place them at greater risk of other complications. Now, we're getting more and more information about that the whole time. Are some of the practices meaning that the patients might be more likely to get more clots than usual? Everyone is doing high quality critical care to the best of their abilities, and we're learning more and more about it day by day and week by week. Mm-hmm. The other thing I think, which has always been there in critical care, is these strong plea from people to try novel untested therapies without them being in the context of a clinical trial. Critical care is a young specialty, but since the first day I walked into an intensive care unit, the first time I went to a meeting, a discussion, we've debated therapies that we think, based on first principles, might be effective in critically ill patients. Now, as the years have passed, we've done more and more very large so-called pragmatic randomized controlled trials. And the executive summary is the vast majority of things that have been tried have actually not benefited patients. And occasionally they have harmed patients. Mm-hmm. So the global community is really strongly urging people to only try novel therapies that might sound like they're a great idea. They might look good if you do N of 1 or only give it to all the patients and compare it to, your own biases. But the only real way to answer these questions is in properly organized trials. And now we've got some more guidelines that have come out to guide us with that thinking.
Now, hearing that, though, like it may sound like you're trying to squash novel ideas or not have people think out of the boxes for treatments, but that's not exactly what you're saying.
Not at all. You're quite the opposite. He's saying this is the time to innovate. This is the time to test rational therapies, but test them using the usual methodologies. And for that, we usually concentrate first on dose finding and safety, and then we look for beneficial effects. And with the numbers that are coming through, these trials are getting done extremely quickly. But just giving something because you heard about it on the Twitter sphere or told you about it over a phone call without checking the evidence behind it, without taking the opportunity to randomize into trials, we should be careful of. We've already seen some reports coming through that one of the dose-finding studies, I think we can put that link in as well, of hydroxychloroquine, for example. The dose-finding studies at so-called 2B phase of trials is the higher dose, as far as I can see from reading what's come through so far, has been stopped in the trial because the side effects we would worry about, which affects the heart rhythm, were being found with the higher doses. So that's been tested now, and based on it looking like it's more harmful, they're not pursuing with that dose of the drug. They'll continue to do the trial, quite rightly so, but not at that dose. And we can put the link to that paper in the show notes as well.
Yeah, that's what I was just going to bring up through all that conversation is that, this is a perfect example. The hydrochloroquine story, chloroquine and zithromax story is that, novel idea, great in theory, not the best idea just to go give it in mass to all of these patients.
Any really strong and effective drug, the stronger and more effective a drug is, the longer the list of side effects. That's a basic core principle of pharmacology, which is why the drug trials usually very, very cautiously and carefully go through these phases 1, 2, 3, sometimes on to 4 afterwards as well. And in the first instance, the thing to concentrate on is the safety of the drug. Because what you don't want to do is to have an unintended consequence of causing harm by doing something that sounded like a great idea. And this is a classical example. They have pursued the dose-finding study, and the high dose of the drug looks like it's causing more harm than good.
Now, Monty, some people will push back on that and say, well, there are already people that are on, chloroquine or the hydroxychloroquine for immune compromised. And so they've already tested this. So how do you deal with that?
Well, it's testing it within the context of the disease process, and it's testing it at the right doses. And let's imagine that this virus makes your heart sensitive to having abnormal rhythms, heart rhythms, possibly it does, and you give a drug that makes your heart more sensitive to abnormal heart rhythms. You shouldn't be necessarily surprised that you get a lot more bad heart rhythms, and they can be hard to treat. Now, that's not at all saying don't try and discover, don't try and test, but stick to this recommendation. There's a great guideline, I think it's a great guideline, came out today from the Infectious Disease Society of America, looking at the treatment and management of patients with COVID-19. Again, we can put that link in the show notes. The executive summary is very quick and easy to read. It's got 7 recommendations in it. And it basically says, of this list of drugs that they've considered the evidence for, which would include hydroxychloroquine, chloroquine, steroids, for example, some of the other antiviral drugs you would have heard about, whether it be the VIRs, we would often call them, the lopinavir or the ritonavir. It says that either don't give them for some of them, or only give them in trials, because as they describe it, there's a knowledge gap. You can't, just by not having it in controlled trials, you can't determine whether they're going to help more than they hurt. And we can answer those questions quickly. We're already the whole clinical community, are already rapidly recruiting patients into these trials.
Yeah.
It's always really, really difficult, and it can often be difficult for, you read something, someone says something on the television, or you read something in a paper, and you kind of think, well, my loved one's unwell.
Yeah.
And you start to think, should I ring up and try and, not the clinicians are thinking about it every day of the week, every hour of every day of the week. If you ring up and start to apply pressure to them to say, have you thought about giving my loved one drug A or drug B? It might be helping them to get better, but you might be encouraging them to do something that could hurt your loved one.
Mm-hmm.
So we have to try and do these things in trials. I think I've said enough about that, but the paper, I think, summarizes it extremely well. It says that there are knowledge gaps. There's only one recommendation where it says something with a degree of confidence, and it says not to give the particular drug.
Right.
That's what it says. It says as we recommend you don't do this based on the available evidence.
Yeah, and that's along the lines of the steroid story. Yeah.
It's. I encourage people to read the guidelines and draw their own conclusions.
Right. Monty, another issue that we have discussed here on Top Med Talk is the story of oxygen depletion and running out of the stores of it.
I mean, that's a well-recognized challenge that we have in any hospital anywhere. Is oxygen in our system, for example, tends to come out in a liquid form is how it's delivered, put into a very large storage tank, and then the liquid oxygen turns into gas oxygen. That's delivered through a pipe system, very much like water is delivered around your household, which means the size of the reservoir and all the pipes in between and the flow rates it can generate means that there are limits to that. Now, I'm lucky enough to work in a relatively recently built hospital that has a very big reserve and excellent flow rates, but we still have to know what they are. It's important that all of us work out what demand we think we're going to put on that oxygen supply, to work with our local engineers, because we wouldn't normally necessarily get up and check the flow rates and the demand on the system every day of the week, because we think of it like tap water. We sort of think that in our world it's never going to run out, if you see what I mean. Whereas the oxygen supplies, as you start to get very, very many sick patients who are drawing a lot of oxygen to keep them healthy, can start to push your system closer to a point whereby it starts to fail. So the important thing is to understand the capabilities of your system, to work with your local engineers. We review our flow rates. One of our colleagues draws it up at every meeting. We look at our flow rates collectively to know where we are on the, how hard we're sucking the gas down, if you see what I mean.
Yeah, so, that's one point. I remember you telling me that, and I think that is such a great idea to include within, rounds and organizational meetings. Every day.
It just makes it sound as though this doesn't happen every day of the week. We don't want anyone who listens to it, but it's an extensively monitored and alarm supported system. We're just not normally sucking this hard.
Yeah. I was just going to say, we don't usually run our flow. We're not running our flows that high for that many patients, for sure. Monty, I just wanted to kind of close in and ask, did you see the Time magazine with anesthesia?
I did. I haven't verified. I don't get Time magazine, so I haven't verified for that, because we have to be really careful with all this
we do
social media stuff to try and verify everything. Have you been able to verify that?
I did. Yeah. It's on.
So there's an anesthesia provider on the front page of Time magazine celebrating one of our colleagues from Italy. We have to be careful that a lot of the light and the clapping tends to head towards the doctors and the nurses. A lot being said about that recently, but it's great to see an anesthesia provider being celebrated on the front page of Time magazine.
Well, what's actually cool about the Time magazine is that they had 5 different covers, and they had 5 different types of healthcare workers that were on their
cool
front pages.
What a great idea!
So it wasn't just anesthesia, and it wasn't just a doctor, but they looked at nurses. They looked at several different people that come out of the hospital and people, warriors in this.
Did the porters, the cleaners, the people who are keeping.
Yeah, they talked about all of those people and all those things.
It's an absolute. Think of any team game. You're only as good as your weakest player.
Absolutely.
And everyone's playing a really strong game at the moment. They're being hardworking, brave people. It's good. Our Prime Minister, who's recovering from COVID-19 in his extremely well-appointed mansion on the western edge of London, quite rightly too, should be resting, gave a very, very emotional speech about the care he'd received from NHS workers.
That's
yesterday.
fantastic.
Yeah.
Well, Monty, it was good catching up with you. I think, for our listeners, thank you for everything that you're doing on the front lines. And we have a lot of people listening that may not be doing direct patient care, but absolutely supporting those who are. And thank you so much for everything that you're doing and for providing that support, because just like Monty said, it takes everybody. It takes a village.
Yeah,
So.
the people in the supermarkets running the tills and stocking the shelves are frontline workers. There's loads of frontline workers. It's thank you, everyone.
Yes, for sure. Be sure to stick with us this week. We're going to hear from some voices here in the U.S. Angela Bader from Harvard is going to be talking to us, a friend of the Top Med Talk family, as well as Dan Engelman and a few others that we've heard from before. So thank you so much for listening. Stay safe, stay well, and we will talk to you soon. Thanks for listening.
Top Med Talk.
It's Desiree Chappell here. Just a quick reminder, subscribe to Top Med Talk. We're a daily source of news and conversation focused on perioperative care. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.
Top Med Talk is proud to thank its sponsors, specifically Edwards Life Sciences, for their generous support through this global crisis.